Good evening. Today's general presentation will be moderated by Dr. Vinata Madam, and we will be discussing on the article that is published on Retina, changes in systemic levels of VEGF after intravitreal injection of aflibercept or brolucizumab for neovascular AMD by Angerman et al. It was published on March 22, 2022. This journal has got an impact factor of 3. Coming to VEGF receptor pathway is important in regulating embryo vasculogenesis as well as adult angiogenesis. It also plays a role in bone formation, hematopoiesis, wound healing, and development. Normally, VEGF is produced by tumor cells, macrophages, platelets, keratinocytes, and in eye, VEGF is produced by pericytes, retinal neurons, astrocytes, Muller cells, retinal pigmental epithelium, and non-pigmental ciliary epithelium. Apart from angiogenesis, VEGF also contribute to inflammatory process by inducing VCAM1 and it enhances leukocyte recruitment and endothelial cell addition. It also increases blood-retinal barrier breakdown. VEGF-A induces endothelial cell proliferation and migration. It has got proteolytic activity and stimulate microvascular leakage. Altogether promote angiogenesis. The action of VEGF-A is mediated by receptors VEGF receptor 1 and VEGF receptor 2. Also, it has got a co-receptor neuropilin. Role of anti-VEGF in neovascular AMD. Due to various stress, oxidative stress and hypoxia, there is upregulation of hypoxia-inducible factor and upregulation of VEGF-A. This is being controlled. This is being the target of anti-VEGF therapy. Bevacizumab is the molecule which is unlicensed. It is a humanized monoclonal antibody against VEGF-A. It has got a molecular weight of 149 kilodalton. And another molecule is ranibizumab, which is a humanized anti-VEGF-A recombinant FAB fragment. It has got a molecular weight of 48 kilodalton. And we will be discussing about aflibercept and brolucizumab in this study. With these basics, we will go to the study. The aim of this study is to analyze and compare the effects of intravitreal aflibercept versus brolucizumab injection on systemic VEGF-A levels for the treatment of neovascular AMD. This is the first study to report on the effects of intravitreal brolucizumab therapy on systemic VEGF levels. Brolucizumab is the latest anti-VEGF medication for the treatment of neovascular AMD. It is a humanized single-chain variable fragment antibody. It inhibits all isoforms of VEGF-A binding to the VEGF receptors. It has got a low molecular mass of 26 kilodalton, and it is the smallest molecule used for ocularly, anti-VEGF used for intraocularly. It provides a sustained VEGF suppression. Hence, it has been labeled to be used at a 8 to 12 weeks interval after a loading dose. The low molecular weight and high intravitreal concentration gradient between vitreous and retina provide effective retinal and choroidal penetration of brolucizumab. A terminal elimination half-life of brolucizumab is 4 to 5 days, and 0.5 nanogram per ml of free systemic brolucizumab is measured 4 weeks after single intravitreal injection. But aflibercept could not be detected 2 weeks after a single intravitreal injection. In the aflibercept, it is a 110 kilodalton soluble fusion protein that combines ligand binding elements taken from extracellular components of VEGF receptor 1 and 2 and is fused to the Fc portion of IgG1. It acts as a soluble decoy receptor binding to VEGF-A, VEGF-B, and placental growth factor. Materials and methods. This is a prospective interventional case series study Indication for a certain intravitreal anti-VEGF agent was determined depending on the patient's preference. 60 patients were recruited who was diagnosed with neovascular AMD and was treatment naive to intravitreal anti-VEGF in past 6 months. A retina specialist diagnosed and classified AMD based on fundus photo and fundus fluorescein angiography. The central macular thickness and macular neovascularization size were measured using OCT angiogram. And these patients were recruited for blood sample collection. Those patients who are having bilateral disease who are in need of concurrent therapy, those having history of vitrectomy or uveitis, those are under systemic inflammatory comorbidities and on treatment with anti-inflammatory medication, those who are having diabetes mellitus, renal diseases, and having systemic vasoproliferative disorders, those patients with history of cancer or previous cancer treatment with anti-VEGF drugs were excluded from this study. So 30 patients were treated with intravitreal brolucizumab 6 mg per 0.05 ml, and 30 patients were treated with aflibercept 2 mg per 0.05 ml, and 30 normal healthy controls were also selected. Sample was collected at baseline from all these three groups, and from day 7 and day 28 in the treatment group. Samples were collected on day 1, then day 7 and day 28 of intravitreal injection. The samples were collected with minimal stasis into citrate theophylline adenosine dipyrimidine tube. This is to prevent the platelet activation and thereby minimizing the cytokine release, including VEGF. These samples were centrifuged at 3000 rpm for 20 minutes. Plasma was collected, aliquoted, and stored. Analysis of sample were done. Systemic free VEGF A level was calculated with ELISA. All samples were analyzed together in duplicate, and the minimum detectable dose of VEGF A concentration was 8 picogram per milliliter. Statistical analysis were performed using SPSS statistics 25, and two-sided test was done for sample size estimation. Binary and multinomial logistic regression adjusted to age, sex, and BMI was used to compare VEGF A level between the treatment and control group. Comparison of systemic VEGF A concentration was in between treatment group was performed using Friedman and Wilcoxon Saint rank test. Coming to the results, demographic and clinical characteristics. The healthy controls were significantly having lesser age than treatment group, but they didn't differ in any other characteristics. Sex distribution and BMI was not significantly different. There was no significant difference between the treatment groups in clinical characteristics. Into VEGF A level, there was no difference between treatment group and control group at baseline. At 7 days, there was significant lowering of VEGF A level in aflibercept and brolucizumab group. But by day 28, the aflibercept group, VEGF A level returned to baseline. But brolucizumab had sustained reduction of VEGF A level. There was a decrease in 96% decrease of VEGF in 96% of patients 7 days after intravitreal injection in aflibercept group. In brolucizumab group, there was a decrease VEGF A levels were decreased in 76% of patients at day 7. By day 28, in 86% of brolucizumab patients, VEGF A levels decreased. Also in brolucizumab group, decrease in systemic VEGF A levels was noted from day 7 to day 28. In the VEGF B level, there was no difference in pretreatment levels of VEGF B between aflibercept group, brolucizumab group and when compared with control group also. There was no difference within and across the treatment group at day 7 and day 20. Placental growth factor levels was significantly higher in treatment group when compared to healthy control group. Both in aflibercept group and brolucizumab group, the placental growth factor level increased from baseline in day 7 and it was decreased in day 28. Compared with the day 7, levels were significantly lower on day 28 in both the groups. But brolucizumab group showed significantly lower systemic placental growth levels than the aflibercept group at day 7. So the study concluded with this sustained reduction of systemic VEGF-A was noted in brolucizumab group, and the greatest effect of reduction was noted at 28 days post-treatment. In aflibercept group also there was reduction in systemic VEGF level, but unlike brolucizumab group, the reduction was less sustained and values returned to baseline within 28 days. Despite of decreased VEGF levels, there was no systemic adverse effect noted in both the groups. The prolonged effect of VEGF-A raises concern regarding safety and long-term effect of intravitreal brolucizumab. Limitation of this study, there was healthy control group was recruited from sex-matched but not age-matched population, but all other clinical characteristics were comparable. Then VEGF-A levels beyond 20 days after a single dose or the VEGF-A levels after loading dose were not assessed in this study. Also, the measurement of VEGF levels in bloodstream, it is complex and differs variedly between different authors, mainly due to whether it depends on whether it is collected from, assessed from serum or it is from plasma. When if it is assessed from serum levels, the VEGF levels will be higher because because the VEGF will be released from platelets also. And even if it is assessed in plasma alone, there will be difference between the different study groups because some anticoagulants are better than others for preventing platelet activation. So there are other studies which was done on other anti-VEGF agents on mainly on bevacizumab and ranibizumab. All those studies have found that there is significant reduction in VEGF levels after bevacizumab injection, but the reduction is not that significant with ranibizumab injections. And what does this decreased VEGF levels mean? When there is a reduction in VEGF, there will be decreased nitrous oxide and prostaglandin I2 production, which lead to vasoconstriction, and this causes hypertension. Hypertension is recorded in 33% of patients who are receiving anti-VEGF for systemic anti-VEGF for cancer therapy. And this decreased VEGF can also cause vascular endothelial cell death. This exposes to procoagulant phospholipids, and this can cause thrombosis. Thrombosis has been reported in 4%. Arterial thromboembolic effects has been reported in 4% of patients receiving systemic anti-VEGF for cancer therapy. But there is in all the registry trials done for intravitreal anti-VEGF therapy, there is no significant side effects has been noted. So whether extensive this systemic VEGF inhibition, whether it increase the risk of cardiovascular side effects in patients with AMD, this currently it is unknown since the registration trials are not powered to answer this specific question. But in patients who are not treated with intravitreal anti-VEGF drugs, But those who are having myocardial infarction, low plasma VEGF levels after 7 days was associated with an increased risk of subsequent embolic events. Also, preclinical studies on aflibercept for solid tumors, systemic therapy of aflibercept also has shown that doses up to 4 mg per kg is safe and side effects are well tolerated. This is much higher than intravitreal doses. So this study take-home messages are that when we are using an intravitreal drug anti-VEGF, consider using the lowest effective dose of anti-VEGF agent. Also consider using treatment paradigms that minimize injection frequency, like treat and extend Pro-Vinata versus strictly monthly injections. Also consider the pharmacokinetics of particular agent while treating patients having higher risk. Like ranibizumab can be used instead of other agents because systemic VEGF suppression is low with ranibizumab. But what we can scope of future studies that there is no data regarding the change in VEGF-A levels in patients experiencing systemic side effects available. Also, a long-term prospective study for patients at risk will be required to measure the systemic VEGF-A levels during these pathological events. And the different systemic adverse effect between the brolucizumab and other anti-VEGF agents can also be studied. Thank you.
Thank you very much, Kasim, for a very concise description of the journal. Like you had said, systemic complications or adverse effects when you take for cancer therapy, you said the hypertension is almost up to 30%, right? Vasoconstriction leading to hypertension. And the thrombosis is around 4%. So we do not have that kind of a percentage in intravitreal injections, do we?
We don't have that kind. There are various reports showing adverse effect following intravitreal anti-VEGF, but there no studies are precisely telling nothing about these percentages.
More importantly, like you said, there are no the VEGF-A levels have not been found out in patients who have had systemic complications, right? Yeah, so that is one point. Another is in this study, I still feel that brolucizumab, they have measured at 28 days, but giving a loading dose of 3 monthly injections would lead to how high VEGF suppression? Because 28 days itself it is sustained. If they think it is a sustained release, maybe they should not give the idea of loading dose and just give one dose and or rather after the second dose and the third dose also one should do the VEGF levels for us to know, because they have a blind concept of loading dose, then one has to at least follow it up every 28 days to see how sustained is the VEGF suppression. Because it's like molecular weight is small, so it's 12 times aflibercept and 22 times ranibizumab, the weight that it is, right? In the cancer treatment, I think only bevacizumab is regularly used, and now they have started aflibercept.
Preclinical studies has been conducted,
but not yet. Probably they may not come into brolucizumab at present.
The loading dose is basically because when all these studies are done, they have to compare with something baseline. And most of those previous anti-VEGF studies are monthly.
with the
And that's why everything is monthly. Even though now we know that duration is prolonged, still whatever usually all those clinical trials we are doing, because drug controller or FDA, when you want to, for them to baseline to compare, you need, that is the reason why you have to have that monthly dose. But most of people now slowly they are realizing, probably increasing the gap. With time, added knowledge will come to know all these things and probably will prolong those. Yes, that's the main issue here.
No, because so much concentration is there.
Exactly, that's we always have that concern. Probably that's why you look at it when there's wherever those toxicity and other effects, side effects, and what we talk about adverse reaction coming up. Those are after around somewhere more than let's say 26 days, but somewhere in after 2 to 3 months mainly, and probably because of that accumulated added dose, most likely. Okay, that's why this produces not with the first injection. Hardly anybody has an issue. Most of the issues are after second or third injection within that span probably. And India, I think, because of our economy and other issues, lot of people already they are gazing on their own. They decided they will delay, and that's why probably number of side reaction. Of course, there is other issue are not reporting, but apparently relatively less compared to what ASRS and others are reported. Okay, that's another thing. Coming to hypertension, yes, it is reported with anti-VEGF injection also. Though dose is minuscule, and typically what we are saying between the window of second to third week, but most of the time we do not check. Okay, that's the reason. But systemic anti-VEGF we are having because of this. Overall, these patients are having a lot of systemic health is the issue. So periodic checkup, regular checkup, they are already all the vitals are being measured. So obviously, it's obviously unlikely will miss. Yes, once we send a patient, now we are not calling them. We only not seeing on a second day also. So why if after 2 weeks or something is there, we do not know. We are not checking. But now with the added knowledge, and also one more parameter we are adding is now there enough. I think at least 3 or 4 articles recently we could see is having a patient those are having compromised renal function. They can get further compromised with anti-VEGF. So probably that one more thing we have to at least, it is not a contraindicated, but what this message has been conveyed is if you have obviously compromised renal function, please check your nephrologist before going ahead and monitor renal function subsequently. They are not saying that it is contraindicated.
Many times, practically patients come back telling that my nephrologist said I have worsened because of injections. You'll have 1 or 2 patients who come back and tell that sometimes.
Most of the time, nephrologists do not know how.
No, I'm just telling. Sometimes
forcing and sending them, and then they write, okay, don't take.
Yeah.
If I have a 80-year-old man coming with CNS, what anti-VEGF injection you will give now, knowing all this data? What will you choose?
Yeah, his other systemic parameters, how it is, that also determine.
Suppose he's had a stroke previously, or he's had a myocardial infarction, then he's on blood thinning agents.
It is better to go with ranibizumab in that case, because the systemic reduction of VEGF is found to be low with ranibizumab, and suppression is not that sustained. Systemic suppression is not that sustained.
Suppose this man had a
with recent history of these things, it will be better to go for another for CN. In case of CNVM, either we can come to the reduced dose 0.3 mg, or better to wait. I think there is no particular cutoff like that, but having a recent history, it will be better to wait 3 months or 6 months.
By that time we'll go blind. Thanks, Kasim.
Thank you.